so good morning or good day, especially if you're listening to this on a Sunday afternoon. I'm Caroline Cook in the Inner Circle, but Caroline Miller professionally, and I'm a metabolic consultant up in Scotland. So this morning, we're going to chat about the health consequences of obesity. Now, obesity is quite a loaded word. Lots of people don't like the term obesity. To me, it's a clinical word, okay? Because to me, when someone is clinically obese, which is the context I use it in clinic, it rings alarm bells in terms of health consequences. Okay, so that's what it means to me. Okay, we try obviously very hard to not be judgmental. So when I see someone who's overweight or obese in clinic, or I've worked out their body mass index and I know they're obese, that's when I know I need to chat to somebody about, the health consequences of that, which is really important. Okay, and I had a young fella in my clinic yesterday, 44, who'd had a pale, sweaty incident several weeks ago with his daughter when he was ice skating with her. The paramedics had been called. He refused to go into hospital. He was told at the time his blood pressure was through the roof, but his body mass index, and we'll come back to that in a wee minute, was 39. He's got dyslipidemia, so his cholesterol, triglycerides are both high. Okay, he's literally, and he's got type 2 diabetes. Okay, so he is sitting duck for a heart attack at the age of 44. And that's essentially what we had to discuss yesterday, which is quite hard to hear because 44, he's a young fella. All right. But we had to go into the ins and outs of that. So obesity is a person who is overweight with an increased amount of body fat. Okay, and we'll come back to the distribution of that in a wee minute. In the UK, it's very common, 1 in 4 adults. And I think there was an NHS, was it 75 years program on last night? I don't know whether anybody caught it, which was quite interesting because Wales are really setting about now. I think 62% of their adult population are now overweight or obese. Okay, I did an audit of my clinic last year over 6 months, and over 70% of my patients had a BMI more than 25. Okay, it's a huge, huge problem. Here's another shocker. 1 in 5 children aged 10 to 11 years are clinically obese. Okay, that's a huge, huge problem. All right. So how do you tell? The most widely used method, and method I use in clinic, I'm going to get pelters here, is your body mass index. Okay. But essentially your body mass index, put quite simply, is a healthy weight for your height. Okay, now I used to advocate the NHS BMI calculator. It is going under, I don't know whether it's under repair or it's under review, but you can't use the NHS BMI calculator at the moment, which is really quite annoying. So I've switched to, I found another one, which is the British Heart Foundation one. Okay, because when patients come into my clinic, I will get a height and weight done on everybody. So I use the body mass index. So it's a height to weight ratio. The simple way of explaining that is I kind of say my husband's a big tall chap, he's over 6 foot, so I can't compare my weight to his weight because I'm not 6 foot. All right, so this way to compare our weights is to do the body mass index. Okay, so healthy weight is 18.5 to 24.9. Okay, now I'm going to say this is for the Caucasian population. All right, and we're going to come back to non-Caucasians in a wee minute. Okay, 25 to 29.9 is overweight, and then over 30 or 30 to 39.9 is obese, and then more than 40 is severely obese. Okay, and we're going to come back to that because I said I use it as a clinical diagnostic tool in a wee minute. You can have difficulties with the BMI. Everybody will know this. What's the problem with the body mass index? What does it not take into consideration?
Well, your muscle mass.
Muscle mass. If you're muscly,
yeah.
woo!
Yeah, if you're muscly, okay. So you can be losing centimeters and your BMI may not be changing or indeed going up. All right. And we know that. And I know that because I have several PTs on my books in clinic who have got a familial disposition to having a high cholesterol. Okay. But they still have to come to clinic. But their BMIs don't mean anything. And I know that because I can see them. Okay, they walk into clinic and I've got their BMI sitting in front of me and it might be reasonably high, and then they walk in and I go, ooh, all right, if I haven't met them before. So I know that, okay. However, even though I've had quite a few patients over the years saying to me, well, you know, the BMI doesn't work because of such and such. How many patients do you think I have look like Linford Christie?
Not many.
Not many. No. Okay. So for the majority of patients, it does work. Now, sometimes it goes the other way. I have had referrals from patients. I haven't seen them yet, but I vetted the referrals and I'm waiting to see them. And I've read the GP referral and they've got high triglycerides. And again, don't worry about this. We'll come back to triglycerides in a couple of weeks. Okay. But triglycerides are just another lipid in the blood that can go off predominantly when you have more fat around your abdomen. Okay. And somebody may have, I've calculated it before they walk into the room because I've had the height and the weight given to me by the nurses. So I've calculated it and their BMI sitting at 25 and I'm sitting thinking, ooh, that's a bit odd. You know, their triglycerides are up and I'm thinking, you know, less likely to be a type 2 diabetic. I'm not saying they won't be, but less likely. I wonder if they're hammering alcohol because that's my kind of third top reason for having high triglycerides. Or is it a familial thing? You know, have they genetically inherited a reason for having high triglycerides? But they then walk into the clinic room and their BMI is 25. But guess what? They've got really slim legs, really slim arms, but they do have truncal obesity. Okay, they have fat around their abdomen. They're just a different shape. Okay, so it doesn't work for everybody, but you know, if you use a little bit of common savvy and take everything else into account. So can anybody remember what do you think I would do if someone comes in and their BMI is 25, but they don't, you know, it's not they've got extra weight around their abdomen? Can anybody remember what other measurement I would do?
Waist.
Weight.
Right, okay. Waist measurement. Now you do this every week because you track your waist. So somebody can enlighten me as to where and how you measure your waist.
The waist should be half the height.
Should be
how
round.
How do you measure it? What are your landmarks in your body?
Belly button.
Round your stomach, just above the belly button.
Yeah. So in the majority of people, it is just above. Yep. So what you want to do is find the bottom of your ribs at the side, okay? And they're quite far down, okay? Find the bottom of your ribs, okay? They are quite far down. And then the top of your hip. There's not actually a lot of space between the top of your hip and the bottom of your ribs, all right? Because years ago, I used to think your waist was round, it's supposed just above my hips, but it's not. Your waist, I always think of it as kind of Simon Cowell's waist, okay? Pretty much where Simon's trousers sit, all right? So yeah, it's a way up. It's not, and I don't like, you know, I don't know, my jeans always sit a lot lower down than that, funnily enough. But yeah, so it's the top of your hip bone, bottom of your ribs, and it's the midpoint between those. In the majority of people, it is, you're right, it's just above your belly button, your umbilicus. Okay, so that's your waist measurement. So that's the thing. So I have a measuring tape in clinic. So if I've got somebody that the BMI doesn't really seem to be making a lot of sense, I will get my waist measure tape measure out and measure it. So that is also very important when you have a BMI over 35 or over 40. The BMI is not as useful in terms, and your waist management's a better measurement. Right now, can you guys remember the centimeters I'm looking for? We'll ask for females first.
80.
80, good. 80. Now, somebody the other day in clinic said, oh, can I have that in inches? I'm a nightmare with inches, so that's me on my phone converting my centimeters into inches. I think, is it 31.4 inches or something? I can't remember.
I don't know. I'm in the United States. We do everything in inches. So when we're trying to switch to metric,
Hang on, I've got a tape measure. Give me a minute. 80 centimeters is 31 and a half.
Yep, so it's 31.4 inches. Excellent. Okay, and then for guys,
thank you so much.
Is it 90?
Yeah, I think it's 94 for guys. Okay. So when your waist is above 80 centimeters in females and 94 in males, you've got an increased risk of medical complications. Okay, so I use a combination of the two. I use BMI and I use my measuring tape as and when required. Okay, because humans are great. We're all funny. We're all different. We're all different sizes. We're all different shapes. Okay, but they're just tools. They're just guides that we use, and they work 90% of the time, which is good. And it means I can have a conversation with the patient. If anybody's seen my previous chat about the BMI, the NHS BMI calculator, I think is really good because it gives you a color-coded bar and it shows you where the 18 to 24.9 is, and then the 20. Well, I kind of say 20 to 25 for easy counting, 25 to 30, and over 30. I don't do the whole point thing because I can't be bothered with that either. But it shows you, green is the healthy, amber's 25 to 30, and then over 30 you go into the red zone. Okay, so the complications, the big thing, once you go over a BMI of 30, you've got an increased risk of the 3 big ones. Can anybody tell me what your increased risk is?
Heart attack.
Heart disease.
Stroke.
Oh, disease.
So cardiovascular disease, yeah, heart disease, excellent.
Stroke.
Stroke, yep.
Diabetes.
Oh, we said diabetes.
Diabetes, yep, diabetes. So type 2 diabetes, yep. And one more, which covers a lot, cancer, yeah. So those are my big 3, okay? So as soon as I have someone in the clinic who's got a BMI over 30, you know, it's increased risk of heart disease, stroke, increased risk of type 2 diabetes, and increased risk of cancer. All right. So that's huge. All right. Okay. So that aside, I'm going to kind of digress from the kind of serious health complications. Let's just chat a little bit about other problems you can have if you're significantly overweight, you've got a BMI more than 30. What other things? Just day-to-day things.
Mobility.
Yep. So you'll have decreased mobility because you will have problems with your joints. Okay. You can have problems with back pain. You can have problems with joint pain, whether it be your knees, your hips. Okay. They're just under more pressure. Breathlessness. Yep. Yep. Excellent. Breathlessness. That's a big one as well.
Overtiredness.
Yes.
Exhaustion.
So feeling tired, and there's lots of reasons for this. Okay. Well, okay. So we use the example. Alex, I think quite a few weeks ago, I remember on the inner circle, everybody was carrying like either dumbbells or backpacks up the stairs or out for a walk, trying to show you your weight loss. So if you've lost 10 kilograms or whatever you've lost, you put it in a backpack, you strap it on your back, and off you go. Right. So you did that, maybe going up the stairs 10 times, or maybe going up for a hill walk. Can you imagine hoofing that around all day? Okay, because that's what you did do before you lost the 10 kilograms. Okay, so you're more tired. You will be more tired because you may not be sleeping well. Okay, and you may not be sleeping well because what things happen when you're overweight? You snore more. Okay, so you may not get a good night's sleep. You also have something called obstructive sleep apnea. Has anybody heard of that? Okay, that's when you actually, it's really, really actually quite dangerous. You can stop breathing when you're sleeping, and it's usually your partner. Now, if you sleep on your own, nobody's going to. Oh, NHS BMI calculator is working again. Thank you, Fiona. That's fantastic, because I will put it in my dashboard.
Yeah, I just used it.
Good. Hopefully it's not my IT setup in the hospital that's having issues with that, but I will look at that. No, it's really useful. Sorry, I digress. The other thing about the NHS BMI calculator, it's really good because the bit that shows you, and you can put it in stones or pounds or kilograms, depending what your patient prefers, or what you prefer, and it gives you the color coded thing, but it also gives you how much weight they think you should lose. And if you need to lose 3 stone, it doesn't say you need to lose 3 stone to get you down to your ideal BMI. It says, right, let's lose 4 or 5 kilograms. Okay, because you're only as good as the first kilogram you lose. There's no point in me saying to a patient, right, you need to drop 4 stone, because they're just going to look at me and think, yeah, not doing that. That's not happening. Okay, so the BMI calculator, the NHS one, takes it down in increments, which is really good. Okay. So yeah, so feeling tired, you can feel tired for all sorts of reasons. Okay. You can also, if you're overweight, have difficulty doing physical activity to begin with. Okay, you may have joint pain, back pain, but you may not just be as mobile. You can't, you're not going to go off and just run whatever and do whatever, and you have to start off slowly. Oh, Sherry wants in. Okay. Any other things?
Stan, I'll give you a shout about 12 because you've got.
Do all of those things accumulate into well-being, mental health issues?
Yes, excellent. So that's the next thing. So the other thing is you can feel isolated. Okay, this can result in depression. Okay, so there's a huge part of mental health here, low confidence and low self-esteem. Okay, and that's a huge part of, being overweight, being obese, not being able to move, not sleeping well, and just really struggling. And if you've got other issues, if you've got issues at home or, you know, issues at work, etc. And this can just, you know, it just adds to the whole thing. So yeah, your mental health can really suffer as well. Okay, so they're all really, really important. It's kind of a holistic approach, looking at the whole body, isn't it? Okay, so any questions so far? No. Okay, so I'm going to kind of move on to the more kind of serious health conditions. So we chatted about heart disease, stroke, type 2 diabetes, and cancer. So in terms of type 2 diabetes, essentially this is directly related to your weight. Okay, because, and I'll do a whole session in type 2 diabetes, but before you become a type 2 diabetic, you're insulin resistant, and you become insulin resistant because of what we call truncal adiposity, or weight, truncal weight around your abdomen. Okay, so there's kind of, you've got normal glucose control, you're pre-diabetic where you're insulin resistant. So you can either say your insulin resistance increases, or you've decreased in insulin sensitization. It's the same kind of thing. Okay. The weight around your abdomen, there's two areas that will be. Can anybody remember where the weight will, the fat will be laid down?
By your major organs, visceral fat.
Yeah, and that's really important. It's visceral fat, so it's around your organs. Okay, so we all know you can get a fatty liver. We'll come on to that in a wee minute, and I did a session on that a couple of weeks ago. So you get a fatty liver, but the fat just doesn't go around your liver. It will go around your kidneys. It will go around your pancreas. Okay, and then you've got a little bit of fat under your skin, which is the kind of subcutaneous, but the majority of the fat in your abdomen will be visceral fat. Okay, and for anybody that's just joined us, viscera is just a fancy name for an organ. So your lungs are a viscera, your heart's a viscera, your kidneys are a viscera. So visceral fat, but the big visceral organ that we think of that's fatty in your body is the liver. And again, we'll come back to this in other sessions, but your liver is the big organ that controls your lipids in your blood, your cholesterol and your triglycerides and things like that. Okay. So if you've got weight around your tummy, you've got more increased risk of becoming insulin resistant and then becoming a type 2 diabetic. Okay, you're not controlling your blood sugars. If you've got more fat around your abdomen, you've got an increased risk of higher cholesterol because of just the liver is the big organ that controls your cholesterol and your triglycerides. You've got an increased risk of heart disease. And these together, you also, if you're overweight, will have an increased risk of high blood pressure, hypertension. Okay, and diabetes, hypertension, and obesity make up something that we call metabolic syndrome. Okay, you may have heard of that. It was really trendy about over 10 years ago now, when I just became a registrar in metabolic medicine. We talked about metabolic syndrome a lot. We don't kind of do that now. I guess we just talk to people about the individual, you know, if you're a diabetic, if you've got high blood pressure, or you're overweight, they kind of come as a triad. And I guess doctors maybe call it metabolic syndrome, but we don't really chat to patients about that. Kind of fell out of favor. Okay. Now, other things in terms of cancer, lots of cancers are related to being overweight, but the top three would probably be bowel and breast. Okay. Breast cancer is related to weight. And again, in terms of HRT, there is risk for being on HRT. Okay, we know that, depending on your family history and your own history. But the risk of taking HRT in some people will be lowered by losing weight, you know, not smoking and not taking on board a lot of alcohol. Okay, because that risk increases your risk of breast cancer as well, all those things. So you can kind of play those against each other. Okay, we've chatted a little bit about sleep apnea. So that's when you don't sleep properly, you kind of stop breathing overnight, you get disrupted sleep. Okay, that can become quite dangerous because some people can just like stop breathing for quite a while, which obviously isn't good. That also gives you disrupted sleep. You then have, you're more tired. So you've got daytime sleepiness. Okay, and then that can result in other issues like road traffic accidents. All right. Other things that can happen, and I'm going to show you a picture now, actually, because we can kind of work our way down the body. Wait a minute. How do I share screen? Let's see what I've got here. Oh, right. Okay. So I'm going to show you this. This isn't to scare you, okay? I just think it's quite a good picture, if that's okay. So I hope this goes down all right. Can you give me a wee nod if you can see that? Okay. Can you see anything yet?
No.
Loading.
See, I'm not at work today, so I'm only
Yes.
using
Yeah.
Yeah.
Got it. Right.
Yeah.
Okay, excellent. Right. It's a pretty grim picture, I would suggest, but I think I saw this at a conference once. It's quite useful. Okay. You can kind of work from your top to your toes, and it gives you an idea of what's going on in terms of overweight and your body. Okay, so if you start at the head, we've already chatted about this. You've got an increased risk of stroke and something called idiopathic intracranial hypertension. Okay, so you can have high blood pressure in your head, for want of a better word. Increases your risk of cataracts. All right, that's when your lens becomes pacified. Now that's reasonably common as you get older anyway, but it increases your risk. You possibly get it at a younger age. In terms of pulmonary disease, so that's just lung disease. You can have abnormal function. If you have asthma or an underlying lung disease that you have already, that will being overweight will make it worse. And I think Deborah, we chatted a few weeks ago, and Deborah has I think come off all her inhalers or doesn't have to use them as much. Okay, her asthma's got a lot better now that she's lost weight. And you get obstructive sleep apnea. Down to the heart next, so obviously coronary heart disease. If you're overweight, you're putting your heart under more strain just on a day-to-day basis, and also you're likely to have increased cholesterol, which lines, the LDL, the bad cholesterol lines the arteries in the heart. And also, if you're overweight, you're more likely, if you've got problems with your joints and just being overweight, you're more likely to have just general inflammation, which we know plays a big role in heart disease. Okay, diabetes. Again, and these are all linked. So diabetes, if you've got truncal obesity, increased risk of type 2 diabetes. And it's funny, we now have even type 1 diabetics. So type 1 diabetes is a completely different, the cause of type 1 diabetes is completely different to type 2. So type 1 diabetes, your pancreas isn't making insulin. Okay, you have to take insulin or you die essentially because it's essential. But I do a type 1 clinic, and I have quite a few type 1 patients who need to take, injected insulin, but they're also becoming insulin resistant because they're overweight. So they're getting the insulin resistant phenotype. They're beginning to act like a type 2 and a type 1. Okay. So being overweight can affect the type 1 diabetic as well. They may be slim when they're diagnosed, but as they get older, they can put weight on. Okay. And also being overweight results in increased blood pressure. Moving down, pancreatitis. So if you have a fatty pancreas, or indeed if you have very high triglycerides, that's the other fat I was chatting about, and we'll do a whole session in that in a few weeks' time. Increased triglycerides more than 10 millimoles per litre can result in pancreatitis, inflammation of the pancreas, which is a very severe medical condition that you can often end up in high dependency or intensive care. Okay, moving further down, and we'll come back to this in a wee minute, you get non-alcoholic fatty liver disease. You can get gynecological issues. Okay, you can get polycystic ovary syndrome and infertility, and then gallbladder disease as well. And then cancer, so top cancers, breast, uterus, cervix, all affected, but pretty much many of the major cancers can be caused by being overweight. Okay, there's a correlation. And then osteoarthritis. Okay, so everybody will probably get a bit of osteoarthritis as they get older, just because your knees and your hips have been doing their thing for 60, 70, 80 years. But you will put increased pressure on those if you're overweight. Okay, and then gout is another one you can get. So gout is essentially a buildup of uric acid. And again, that can be, it's increased when you're overweight. Okay, so basically head to toe, it affects the whole body. Okay. A little bit about fatty liver disease, just in case you've joined us. And again, I do a full session on this, but I'll just go over it again because I think it's quite important. It's not something that's known a lot about, and I'm talking about non-alcoholic fatty liver disease as opposed to fatty liver or alcoholic fatty liver disease. There's a difference. If you drink quite a bit of alcohol, it's to do with the alcohol. It may be to be with being overweight and drinking alcohol, but you can't say it's non-alcoholic fatty liver disease. So NAFLD or NAFLD, is how we like to call it, because obviously non-alcoholic fatty liver disease is a horrific mouthful. Okay. There are different stages. Okay. You have the simple fatty liver, where this may be picked up quite insidiously because you will have no symptoms from this at all. It may be picked up because you've got a blood test done at your health centre and you're told that your liver function tests are off a bit. Okay. And then it moves on to an inflamed stage, stage 2, which is non-alcohol steatohepatitis. And that's just basically fat, and hepatitis is just inflammation of the liver. And then the next stage is fibrosis. Liver still functioning normally because your liver is a cracking organ. Okay, all your organs are very good, but your liver is really good because you can really push it somewhat before it really gives up the ghost. Okay, and then the 4th stage is cirrhosis, and that's the most severe stage, and that's irreversible. Okay, and that's the same kind of cirrhotic liver that somebody who's alcohol dependent can get. Okay, but with this stage, your liver goes big and inflamed, fibrosis, and then cirrhotic. By the time it's cirrhotic, it gets a lot smaller and really isn't functioning, and it leads to liver failure and indeed liver cancer. Okay. Increased risk for non-alcoholic fatty liver disease, apple body shape. So again, truncal obesity, type 2 diabetes. We look out for this if you've got type 2 diabetes because you've got an increased risk of this. High blood pressure, high cholesterol, more than 50 years of age, and also smokers. Okay. So there's a lot of risk factors there for non-alcoholic fatty liver disease. The good news is, though, that's all reversible if you get it in the first 2 stages. Okay. All right. And it's usually just found by, as I said, just random blood test by your family doctor for whatever reason. Okay. And there's no medication for it. Okay. We chatted about this. It was either last week or the week before. So what do we do for non-alcoholic fatty liver disease?
Look at my notes.
Diet and exercise.
Yes, diet and exercise. All right. There are no easy answers. All right. It's all got to do with lifestyle. So lose weight. And even if you even if you change what you eat, you can remove some of the fat from your liver without weight loss. But if you lose, we will definitely reduce the fat in your liver. Okay. You will also, if you lose weight, especially around your abdomen, you will decrease. Either if you're type 2 diabetic, you will bring your blood glucose levels down, or if you're not a type 2 diabetic and you're pre-diabetic, you'll move your insulin resistance down as well. Okay. So for anybody that's new, steps, I'm really keen for everybody to do at least their 10,000 steps a day if they can, or as many steps as you can manage. So if you did 2,000 yesterday, 3,000 is good to aim for today, because any steps will help. Why am I interested in steps and just moving in general when it comes to insulin resistance or type 2 diabetes?
Because it opens the door.
It does open the door, Denny. Excellent. Now everybody's thinking, great, Denny and Caroline have lost the plot. Okay, so and again, we'll do a whole session in diabetes, but in terms of insulin resistance, we know insulin gets glucose into cells. Okay, and I have a really simple model for this, and believe me, this is very simple. If you think of a room with 2 doors, okay, the first door, I want to get glucose into the room, so I'm standing outside the room. I am glucose. I want to get into the room. How do I do that? Well, the first tool I can use is insulin. So I use insulin. Insulin knocks on the door. The first door opens. I can walk into the room. When you're insulin resistant, the insulin has to knock more than once. Okay, it knocks once, the door doesn't open. It might have to knock 2 times, 3 times, 4 times. By this stage, your pancreas is thinking, for the love of God, it's now having to produce more insulin. It's not very happy. Okay, your pancreas, you may be 50, 60 or 70 years old, so you've got an older pancreas to begin with. But that's what insulin resistance is essentially. Okay, the insulin is having to work harder to do the same job. But there's a door 2. So what happens door 2, Denny? How do I get door 2 open?
Walk out in the fresh air.
Yeah, so I want to exercise. To get door 2 open, I want to exercise. Okay, and we know this because we know in type 1 diabetics who have to take insulin, if they exercise, they have to be very careful because they can go what we call hypoglycemic. Their glucose can go really low. All right, and that means if they're exercising, they have to do one of 2 things. They either have to reduce the insulin they take, or they have to take on more carbohydrate. Okay, if they're athletes or doing a lot of work, they have to take on more carbohydrate, okay, because they will actually go low. And I've had patients who have gone hypoglycemic after 3 hours of ironing. Why anybody wanted to iron for 3 hours, I have absolutely no idea. But it happens. It doesn't have, you don't have to be running a marathon for it to happen. You just have to be moving. All right. And that ties in well with NEAT. What is NEAT? And again, don't panic if you haven't heard any of this. I will come back to this.
Non-exercise activity thermogenesis, something
Genesis,
like that.
excellent, Angela.
Anything that's other than
absolutely
exercise.
brilliant. So essentially, in terms of your metabolic rate, how you burn calories in a day, about 60% of that is just you sitting there doing nothing, breathing, and your muscles doing what they do when you sit upright or when you lie down, your heart working, your kidneys working. But the next big part of your energy expenditure today in the day is your NEAT. It's not the 60 minutes you go and do in the gym. It's your NEAT. It's walking from the car, either walking to the shops and not using the car at all, or walking to the bus stop, or parking at the far end of the car park when you go to your supermarket. Because you get 2 hits with that. The 2 hits are, one, you have to walk all the way to the supermarket and then back again. You also get to carry your shopping bags from the supermarket back. So you do a bit of resistance training as well. Okay. And that's all your non-exercise activity thermogenesis. And that will all be allowing glucose to go into your cells and decreasing your insulin resistance. All right. Okay, so anything else? Right, there's another little thing. I don't do a whole, I have to leave that mic next week, but we'll catch up. No problem, Isabel. So the other one that I don't actually do a separate session on is kidney disease. Okay, so your kidneys will also get fatty as well. So chronic kidney disease, or CKD, as we call it in medicine, is common, and it is associated with getting older. Okay, you will more than likely have CKD the older you get. Okay, just because again they've been doing the same old thing for quite a few years. But I often say to patients, do you know you're in CKD stage 3? And I get this kind of wow. Okay, they haven't realized. And what your kidney disease is usually looked at by a blood test, and then if you have issues, they'll move on to using a urine test. And anybody with diabetes will know they will should get a blood test and a urine test to look at their kidney function at least once a year. Okay, and we'll go into that again when I'm chatting about diabetes. But your kidneys are really important. Apart from mental health, they remove waste. We know that, but they're involved in controlling your blood pressure. Okay, and your kidneys are also damaged by having high blood pressure. So it's very important that if you have high blood pressure, that it's controlled. And initially, before you lose weight, the chances are you'll probably need medication for this. Blood pressure is very difficult usually to manage because apart from anything else, you don't feel it, not unless it's incredibly high. Okay. But I was in my clinic yesterday and everybody I saw had high blood pressure. I actually went out at the end and I said to the nurses, I said, can we have a wee look at the blood pressure monitor? Because I swear every patient today's had high blood pressure. And I'm now beginning to think the machine's not working. But I was assured there were other patients that had gone through that their blood pressures were okay. And I just thought, okay, nobody likes coming to see me. Their blood pressure goes through the roof. But blood pressure is really important. Okay, and we'll do a session on that. But high blood pressure can damage your kidneys, and your kidneys control your blood pressure. Diabetes will damage your kidneys. Okay, diabetes is the biggest cause of end-stage kidney disease in the UK by a stretch. It's the biggest cause for dialysis in the UK and transplant. Okay. Cholesterol is also important when it comes to your kidneys. Your cholesterol will be clogging up your arteries in your heart and your head, but it will also build up in the vessels that supply your kidneys. Okay, which makes it harder for the kidneys to work properly. Okay, so simple tests for kidney function. First one's a blood test. Okay, and then you can get a urine test just to look at the albumin or the protein in your pee. I explain this essentially as your kidneys are a big sieve. Okay, so if you think of a sieve and you think of albumin, the biggest protein in the body that circulates in your blood, as peas, okay, as in the vegetable peas, as opposed to PP. All right, so vegetables, peas. When your kidneys are functioning well, water runs through the sieve and the peas all sit in the sieve. Okay, when your kidneys begin to get leaky, the holes in the sieve become larger and the peas drop through. Okay, and that's essentially like protein going into your urine. Okay, that is a big sign that your kidneys are not functioning properly, and that is when a lot of diabetics have to be referred to the renal doctors. Okay, because their kidneys aren't working as well. All right, you can get protein in your pee for other issues, such as you may have it sporadically if you've got a urinary tract infection or something like that. Okay, but that's just because there's inflammation when you've got a urinary tract infection. How treatment for kidney disease, losing weight, funnily enough, blood pressure medications and cholesterol medications are all important. Okay, if you've got kidney disease, it increases your risk of heart disease, and lots of people with kidney disease often have diabetes, so there's kind of a double whammy there. So these patients, we would be fighting very hard to get their cholesterol down. Okay, so they're more than likely to be on a medication called a statin. Okay, but again, we'll do a session on cholesterol. Okay. So kidney disease, again, happens commonly as you get older, but also if you get high blood pressure, you'll be damaging your kidneys. If you get diabetes, you'll be damaging your kidneys. And if you're overweight, you'll be putting more pressure on your kidneys because of the above. Okay. So obesity, it does decrease your life expectancy. Okay. And I think Alex on Monday night's live, you know, if you lost so much, 10% of your body weight, you increase your life expectancy by 9 years. Well, the converse is true. If you're overweight or obese, you've decreased your life expectancy on average by 3 to 10 years. All right. So it is important. Okay. And just a little bit on metabolic syndrome again. So that's basically the trio of diabetes, hypertension, and obesity together. Okay. And again, so treatment for overweight, basically, essentially, I guess, what do you want to do? You want to move more. Nutrition, what kind of things do we want to do nutrition wise? I have one simple sentence for this.
Eat the rainbow.
Eat the rainbow. Yes, Jane, you've been listening to me far too long.
Yeah.
All right. Yeah. So as far as I'm concerned, eat the rainbow, not white, lots of brown. Okay. And watch the cheese. All right. I was getting a lot of grief at the weekend for saying cheese, you don't get a lot of bang for your buck. Well, you don't. If you weigh out 20 grams of cheddar is about 100 calories, and it's like 20 grams of cheddar is nothing as far as I'm concerned. So yeah, so eat the rainbow. Okay. By the time you come into elite, you're probably thinking more about your macros and things like that. So you'll be watching what protein you're taking in, and your carbs and your fat will be reasonably low anyway. And if you're following your macros, that kind of dictates what you eat, doesn't it? Because if you're keeping your fat at a certain level, you're not going to have a lot of refined carbohydrate. And refined carbohydrate is one of the things that increases your risk of non-alcoholic fatty liver disease and type 2 diabetes and obesity. And essentially, the issue with refined carbohydrate is if you're not moving very much, you take your refined carbohydrate, you've replaced your glucose stores and your muscle in your liver, you will essentially, your refined carbohydrate will get converted to fat. Okay. So that's the issue, but it's not all carbohydrates at all by any stretch of the imagination. Okay. But yeah, so healthy diet, increase your exercise. Now we know there's a lot more than that, because as again Alex was saying on Monday night, eat less, move more. There's a whole behavioral issue behind this, which is actually very, very difficult to deal with, especially on an NHS scale, I think. Okay, it's not that simple. But everybody here has obviously signed up to TSD. And again, I always go back to the 6 doctors. Can we just run over those really quickly before we finish? If I struggle with, if things are kind of going off plan, and I think it is very difficult. I think at the beginning my first 12 weeks, definitely the first 6 weeks, I was one of those. I was hitting everything 100%. Alex said very, very quickly, you're not going to, you're not going to continue to hit this 100% because you can't. So, but if you hit it 80% of the time, you're doing well. And if something's going off, you have to kind of rein it back in. And it's like, I kind of think of it as like juggling the 6 plates in the air, the 6 doctors. So 6 doctors, for anybody that's new, I've put this in Inner Circle a couple of times over the last year and a half. It's kind of the 6 principles, I guess, that if it's all going pear-shaped, if you're having family issues, work issues, or just life issues in general, if you kind of write these down in a piece of paper and address any of them you're having problems with. So can somebody give me one of them?
Water.
What was that? Water?
Yeah.
Yep. Water.
Hydration.
Okay. Yep.
Sleep.
Sleep. Yep.
Sunshine.
Sunshine, yep. So yeah, sunshine and fresh air, huge. So that's getting out for your walk essentially. Yep, sunshine, fresh air, that's possibly 2. Water, sleep.
Exercise.
Yep.
What's your food?
Protein.
And pardon?
Protein.
Yeah, so just, yeah, nutrition in general. Okay. So if you kind of, those are the, you know, if you're sleeping well, you're going to be making good food choices. You're going to be, you're going to feel better. So you've got more time to prep your food. If you've got more time to prep your food, you're more likely to eat more nutritious food, eat the rainbow, not just grab something. If you're drinking your water, that stands you in good stead for your exercise, whether it be your resistance training or cardio. Okay, water is very important, especially over the last 2 or 3 weeks, even in Scotland. Even in Scotland, it's been very warm, which is quite unusual. And then the air, walking. So, well, walking's your steps, okay, but that's also good for your mental health, which is incredibly important. Just getting out there, and very nice at this time of the year. I think this is something that I think from, you know, end of October to March is more difficult, and especially up north it can be a bit gloomy here. But that's when I go on to my top trick for that is I've got a treadmill, so I move into walking indoors and hit all my Netflix series that I can't watch with my husband because it's all the chick flick rubbish that he's really not going to watch. So I watch all the nonsense of the, and I'm actually missing that at the moment because I'm not watching any trash. All right, because if I'm walking or going out, it's outside now, and I can't do that. I listen to stuff, but I don't watch a lot of stuff. So, okay, right. So that's essentially just a kind of whirlwind view of the health consequences of obesity. Has anybody got any questions?
Can I ask a question?
Yep, sure.
When you do your waist measurement, are you pulling the tape measure tight as it will go, or very, very loose, or something in the middle?
If you go to the British Heart Foundation website, they give you how to do your waist measurement. Okay, and I actually cover this in one of my sessions, because I'm nearly sure there's rules of engagement about breathing in and breathing out. Okay,
Yeah.
you do have to be relaxed because you can make 2 or 3 centimeters disappear or appear quite quickly, I think. So yeah, I think you basically, it's fairly tight. So you find your landmarks, put your tape round, but I'm nearly sure you breathe out. Okay, you can't be doing the whole, you know, you see guys on the beach sucking it in. That's not your true waist. Okay, so yeah, I think you find your landmark, put your tape round. It's fairly tight, but you do relax. Okay, and that'll give you your true waist measurement. Okay.
Yeah.
You were talking just then about kidney disease, and you said that you can reverse fatty liver disease. Does the same apply for the kidneys? So if you've been diagnosed with perhaps stage 1 or 2, can you reverse that back?
Okay, so yeah, so stage 1 or 2, this is quite funny. In Scotland, or the lab I work in, and I don't want to go into this in a lot of detail because it's really quite complicated. We work out, I'll tell you a little bit about this, and it may mean something to some of you, but probably not. So your E, so small e, GFR is your glomerular filtration rate. And you can see why we see GFR, can't you? Because I can hardly say that. Right, so it's estimated glomerular filtration rate. That is calculated. There's a huge equation to calculate that. And again, I'm not going into that, but it's based on, one of the factors in it is your creatinine. Okay, so there are lots of caveats with this. We know it is not, it's okay at predicting what your kidneys are doing, but it's not spot on, right? There are other ways of doing it, but we don't do it in the NHS on a huge scale in the UK at all, okay? Because your creatinine can vary, okay? So I watch people's EGFR probably getting better in hospital, but they've been more abundant ITU, and we've got an issue at the moment with a patient who people aren't thinking that they're dry, they're dehydrated, and I think they are dehydrated, but their EGFRs got better, but I think it's because their creatinine's plummeted because they've been more abundant for 4 weeks, and they will have lost a hell of a lot of muscle in 4 weeks because they'll have been catabolic, okay? Anyway, I digress. So CKD stage 1 and 2, we don't clarify those up in Scotland. We first tell you you're in CKD, chronic kidney disease, when you're stage 3. And your EGFR at that stage, its mils per min is 45 to 60 mils per min. If it's more than 60 mils per min, we just say your kidney function's fine. But you're right, CKD stage 1 and 2 will be between 60 and 90, but we don't differentiate that, Denny, okay? You will, the thing with CKD stage 3 though, is you could go into CKD stage 3 when you're 55, 65, 70, and you may just stay there for the rest of your life and have no issues, okay? The big thing about CKD is a rapid change. So you pop into CKD stage 3, and if I notice that in one of my patients straight away, I'll say to the GP, can you repeat that in a couple of weeks' time? If it's stable, it's fine. If it's decreasing, that's when you've got issues. But I don't think you usually, if you're in CKD, you can go into CKD stage 3 by just being dry. So I've had quite a few patients recently. I've got preclinic bloods done. It's been hot. Predominantly guys are not drinking enough water. So the other marker of you being dry is your urea, okay, which is a waste product that your liver produces, but is filtered by your kidneys, and it goes up, and you basically go into CKD stage 3, okay, or you're dry. And I have to phone the patient and say, look, you're going to have to drink more water. They drink more water, and their kidneys are normal, you know, a week later, which is fine. So you can kind of bop into CKD stage 3. You can also go down to CKD stage 3, 4, or 5 if you go into acute kidney failure, if you've been incredibly ill or something's happened. You go in hospital, you get lots of fluids, blah, 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 and then you can go back to having normal kidney function. So that's kind of acute kidney injury, okay, as opposed to chronic kidney disease, which is CKD, all right? But to answer your question, Denny, if you go into CKD stage 3 and you're in it, I don't think you reverse that. Like you know, we can give you fluids to get you back out, but you may have done damage, or you just may be 70, 75 or 80 years of age, and that's just what your kidneys are doing. But you can live for years with CKD stage 3, okay, and nothing will happen and it'll be fine. We're interested in it from a medical point of view because there are some drugs we can't give you if you're in CKD stage 3, or we have to half the dose if you go into CKD stage 4 or 5. So that's why we're interested in that. Diabetics will be followed up if they go into CKD stage 3, because if that, again, as a diabetic, you may stay in CKD stage 3 for years and not have an issue, but your kidneys may deteriorate, and that's when you may have to go into dialysis and something. So it's really quite complicated. The simple answer to your question is, I don't think there's enough information about fatty kidneys. We don't scan kidneys to see if they're fatty. We scan your liver to see if it's fatty, and we can see that being reversed. But I never scan your kidneys to see if they're fatty. We've just made the assumption that if you get a fatty liver, you're likely to get fatty kidneys and fatty pancreas. But we don't. That's not a medical thing that we scan or look at. Okay.
Okay, thank you. That's helped me.
That was a bit convoluted. Okay, so this week's challenge from me is
another one.
yeah, well, you see, I don't know whether that was good timing or not. I just came off the weekend, and my Facebook page had just basically been polluted with doing 1,000 push-ups. I think it's cancer research we're doing it, okay? And I kind of thought, yeah, we've come back from Tough Mudder. Lots of the ladies were saying, oh, that was really good, but my upper body strength. And I thought, I quite fancy having a crack at 1,000 push-ups a month. And I think from my point of view, we did squats. It was ages ago, I think, through TSD. We did squats one month, nearly killed me. I actually didn't appreciate, I do squats, you know, with my barbell, but actually doing squats every day, just normal squats, just no weights, just normal squats. And I was thinking by the end of it, my legs were jiggered. And I kind of thought, right, let's have a go at the push-up thing. And I thought, I'm more likely to do it if I rope everybody else into it. purely selfish point of view. All right. So I put it on, and of course, next Alex turns up in the live Monday night and says, oh yeah, let's do push-ups. I'm thinking, ooh. So there was no, I thought,
so you're to blame.
Well, no, I don't think so, because I don't think he'd seen my post. So I think that was just he'd you know thought the same thing. Let's keep going from the weekend kind of thing. I haven't started mine yet, though. You're all very keen. I'm starting mine on the 1st of July.
I signed up. Yeah, I signed up to the official challenge yesterday.
I saw that, Jane. I saw that.
I won't start the 1,000 until Saturday, isn't it?
And is everybody just warming up? No, I'm going to start on Saturday, because I'll need to get. Well, I know. Yeah, starting off, I think I'm just going to build mine up 5 and then 6 and then 7. But by the end of the month, I think you have to be doing 45, and that's going to be. I obviously won't do it in a oneer. They will be spaced out throughout the day. But I was speaking to Michelle Reeve, one of the coaches, and she kind of said, oh, we should get people to do them in funny places. And Alex did a cracking challenge once. It was ages ago. It was when I was in the first 12 weeks. And it was, you had to get dressed up in something that you would, wear out, like a dress or a skirt or whatever. Okay, but you had to go and do something quite random. And I remember somebody took a photograph of them putting the bins out, and I thought it was absolutely fantastic. It was just really, really good. So Michelle said, yeah, why don't we do them in really odd places? And I'm thinking, right, okay, we'll see.
What, like in
so-
Tesco?
Yeah.
Well, yeah, if you wanna get down and do 10 in Tesco, fire away. So my other challenge, and this is much more simple, okay, and will not take 30 days, I can assure you. So I want you to pick a health issue, because we've been doing about health issues to do with obesity this morning. Pick a health issue that you feel you have reversed, overcome, made better due to recent lifestyle changes. Now that could be anything. That could be your blood pressure, it could be your HbA1c, it could be your mental health. You could basically say, before I joined TSD, I didn't walk, or I didn't walk very much. I now never fail to get my walk in at 6 or 6:30 in the morning, and that just really sets me up for the day from a mental health point of view. Okay. So before TSD, I was a diabetic, had hypertension, had problems with reflux, had mental health issues, whatever, and now I'm blah. Okay, and just say what it's improved. Now several people will have a myriad of things that they can chat about, but yeah, I thought that would be quite good. And again, it lets other people in the inner circle see, and I think that's good for people who are just onboarding or coming into TSD, because they can see what's down the line, kind of thing. Okay, it might be as simple as I've put a bikini on, or I've either put one on or I'm planning on putting one on. I would in a hairy fit would I have done that 6 months. I think I wore a bikini last year when we were on holidays, and in a hairy fit would I have done that before. So and that's loads things. That's a psychological thing. It's lots of different things. All right, well, it's that time again. I'll have to say goodbye, but thanks for listening again this morning. Next week